Janice Penner. I'm the manager of the FASD Initiatives Unit with Alberta Human Services and co-chair of the Alberta FASD Cross Ministry Committee. It is my pleasure to welcome you today to today's webcast, a case study, Siksika Health Services FASD program. It's part of a monthly series of webcasts on issues relating to FASD. This webcast is part of the Alberta FASD Cross Ministry Committee's initiative and 10-year FASD strategy to provide educational sessions that cover a broad range of topics that are accessible to all Albertans. For more information about this series, check your emails for our regular updates or go to hslearningseries.ca or follow us on Twitter at AB Human Services. Today's webcast will cover how Siksika Health Services has adapted a relationship-based home visitation model of support for the First Nation community they serve. It will address details of the individual and family care model and their cultural model of care. You will be able to pose your questions to the speakers via our live chat window. We will address as many of these questions as we can at the end of the presentation. Let's start off today's session with some introductions. Our speakers today are Vanessa Buckskin and Suzanne McLeod. Vanessa is from the Blood Tribe Blackfoot Nation and is the FASD Clinic Coordinator for Siksika Health Services under the Community Wellness Programs. She has been passionately working for 10 years in the area of FASD and programming for intervention, prevention, and overall development within the First Nations communities she serves. Vanessa received her Bachelor of Health Sciences, specializing in addictions counseling, from the University of Lethbridge in 2005. Suzanne is Anishinaabe from Saging First Nation, Manitoba, and has worked with Siksika Health Services since 2009. In special projects lead. She is currently completing her PhD through the University of New Mexico and holds an MA and BA in the areas of Indigenous issues. Her areas of focus are social and community development that support the political and economic advancement of Indigenous communities across Canada. Our moderator for today's session is Eric. He's our online moderator. He'll pose your web chat questions to our speakers. Today's session is also being recorded, and the video will be posted on the Alberta FASD website in about 2 weeks after this live session. Now, I'd like to hand it over to our presenters, Vanessa and Suzanne. Welcome.
Good afternoon. Oki Nidanago Kakadosaki. Welcome everyone today. My name is Vanessa Buckskin. My traditional Blackfoot name is Star Woman. And today I'd like to present our model, the FASD program, that is being offered on the Siksika Nation. The FASD program is a unique model within First Nations, as it is the first that is provincially funded from the Cross Ministry Council. It is a unique program that offers prevention services, awareness services, and clinical services to the community at large. The two diagrams you see are from the health center where the services run under. Siksika Health Services is the main logo that is attached to the presentation. The second logo is a logo that was made by our community member, a grade 6 student, who we had presented our services to in our awareness presentations to. So we honored that child by having this logo presented in our overall program services. I will introduce the staff. The program offered in Siksika is a modified PCAP program. We do offer full home visitation program services, but we also understand the needs of our community and that we are First Nations, and we are First Nations that are members of the community itself. So the four positions that are offered within the community are all unique to their job titles based on the needs of the community. So like myself, Vanessa, I am the coordinator of the program, and I oversee the program at large. So the administration part, all that lovely stuff of paperwork, negotiation, looking at who can support our program services, advocating for the other agencies to become more involved in community services, that's my role. And then what I'm doing today, presenting to you. We have 3 staff under us as well, and their positions are just as important as mine. I wouldn't be able to do any of this work without the 3 ladies that are involved in the program. The first one I'd like to introduce is Michelle Weaselhead. She's our FASD support worker, and she does a lot of prevention work within the community. So her role is to go out and provide awareness on services to all ages. And I literally mean all ages. This woman has gone out and provided presentations to the Head Start students, to elementary students, and to the whole community at large. She comes with a lot of skills that address what is needed out there and how we can talk to the students to have them more aware of what's going on within the community. She also has a dual position. She is our adult mentor as well for individuals who are affected by FASD or who are suspected. So her home visitation is very intense as she provides a lot of one-on-one and individualized specialized case management. Our second employee is Tyann Redgun, and she's our clinical assistant. She also has a dual role. So all the stuff that we do within Siksika with the clinical part of diagnosing the children involved in the program, Tyann helps with that. And with a whole multidisciplinary approach, there's a lot of work behind it, and a lot of that is paperwork. That's a lot of running around to the schools, to agencies, and other individuals involved, the parents, the foster homes. Whoever's involved with that child's life, Tyann is the one that goes out and accesses all the stuff that is needed to provide a diagnosis. She's also a mentor, so she provides one-on-one support with individualized case planning as well. And our last employee is Tanji Scoutblock. She's a program mentor that also holds a dual role. So she provides one-on-one support to the families who are involved in the program, but she provides a lot of awareness to the community at large. So she's more specific to the adult community, and she provides FASD one-on-one, strategies to support parenting, and just a broad awareness of how we can support these individuals within our community. So I want to talk a little bit about Siksika. Siksika is the second largest First Nations community within Alberta. It is part of the Blackfoot Confederacy and the Treaty 7. What you're seeing is a diagram of how large the reserve is. It has 100 I'm suffering from a cold, I do apologize. 100 kilometers long and 50 kilometers wide. So it is fairly huge. So when you really think about it, 4 employees to cover this mass amount of population is a huge job, especially when it's target specific with FASD. So it's the second largest, like I said, and I kind of want to just hand it over to Suzanne right now to provide a background of how the community, the FASD program came into the community. Sorry.
Good afternoon, everyone. Just to let you know that Siksika Nation itself is located about an hour east of Calgary. It is part of the Treaty 7 area. There's 3 treaty areas in Alberta, Treaty 6, 7, and 8. Treaty 7 is located in southern Alberta. And the nation resides along the Bow River. It is the second largest First Nation in Canada, actually, in terms of its geographic location, not necessarily its overall population, but in geographic size. And it is part of the Blackfoot Confederacy. Now, the FASD program in Siksika itself has been in development essentially over the last 10 to 12 years. The program started in 2007 under Community Wellness with Siksika Health Services. At that time, it was called the 7 Stars Clinic, and it was a diagnostics-only clinic. It was supported through Health Canada. And Dr. Fred Banning, I'm sure a lot of you are familiar with him, was really instrumental in supporting and the overall continuity of the FASD clinic on Siksika. Now, we also had an FASD support worker that was also funded through Health Canada. We've since expanded this position, and Vanessa will talk more about that. Now, funding for this FASD clinic for the 7 Stars was reallocated at that time, and so we didn't have the diagnostics for a couple of years, but again, Dr. Fred Banning was instrumental in the continuous support of the program. And he was key in bringing it back in about 2010 through his constant, he was very consistent in coming up to me and saying, do we have funding? Can we find funding? Is there a way that we can get supports? Is there a way that we can bring in people? And so he was I cannot stress enough the role that Dr. Banning played in the overall success of this program. Now it is housed under the Intervention Prevention umbrella from Health Services. We still have the FASD support worker position, and that is Michelle Weaselhead. And this is an expanded, enhanced position that Vanessa will explain a little bit more. And it is a partnership-oriented clinic that we run. Now, we form working partnerships with Renfrew Educational Services in Calgary. They provide us our medical diagnostic team. And so we've formed a really good working relationship with them. We also have a cost share partnership on reserve with Siksika Family Services. And they provide the funding for for many of the positions that we have, including the clinic coordinator and the home mentor position. And without their cost share partnerships, we wouldn't be able to run the program as we do. So the emphasis is on relationship building and the home visitation program. Now it still currently operates under the umbrella of community wellness as part of health services. And it really is an enhanced visitation program. So Vanessa will explain the need that we have within the First Nations community and the direction of the home visitation program. We currently work under CFAN, or we currently work with CFAN as an enhanced follow-up program. And so she'll explain why the program is unique within the First Nations capacity and how we could possibly bring that to other First Nations.
Okay, so now that we know a little bit of history of how the FASD program came to Siksika, I want to talk a little bit about the model of the program and what we follow with program services and providing awareness to the community. Like I had mentioned earlier, it is a modified PCAP program, and I will explain in detail what that means and what that looks like for Siksika Nation. But I will talk about 3 models that we model after with delivering program services to the community. So the first model I'd like to talk about is the FASD clinical model of care. And what this model basically is a multidisciplinary model, meaning that we take on the same services as Renfrew, with the support of Renfrew Services, and they support our community with providing the multidisciplinary approach to diagnosing children with FASD. So what makes this program, this partnership so unique is that within a First Nations community, we face large barriers. One of them is transportation, commitment to appointments, and the stigma behind FASD itself. So with having Renfrew Educational Services come onto the reserve and provide the testing right on reserve within the community makes it more open for the community to accept this support that we are providing. It is a non-judgmental environment. We were there, we walk them through the whole process from day one. Appointments are made strictly through us. The whole flow of the clinical process goes through our program. So when a child is going to be assessed, we're the ones that we're the people that take on that load for them. So the appointments are made through us. The assessments that are brought out to the schools, we do that legwork. The assessments that are brought out to the family service workers, the assessments that are brought to the caregivers are all done by us. The family is given as much support through this process, but we take on the huge role of having this process flow as simple as we can for the family. Because within a First Nations community, we're finding that if we provide this kind of support with children who are being diagnosed, diagnosis actually becomes a success for them because they see the importance of it and they see how we are supporting the community in general. So when a child is diagnosed, all the services are brought to Siksika. So like I said, Renfrew, it's a huge thank you to them because they provide this to the community. They provide us with a psychologist, the occupational therapist, the speech and language, and an FASD coordinator that coordinates all the documentation on their end. On our end, our little Tyann takes care of all that part, the clinical services. So she gathers all the documentation. So that's what makes it key within a First Nations community is we brought this tough stuff to the community and made it easy. It's an easy process from day one because like I said, and I want to keep mentioning it, it's a huge load off the families because we make it easy and we let the community know that we're there supporting them from day one. So the huge part of the clinical process is taken on by our program. The pediatrician that's involved in this whole process as well is from the community. It was Dr. Fred DeBanning, and like Suzanne had mentioned, he was a huge role in this because he was the one who had the support of the families from day one. He's the one that talks to the families and gets the children involved in the program and knows these children inside and out. So he was part of the community as well. So a lot of the supports that the families get from day one are from us. I want to mention here too as well with providing FASD diagnosis, they're not getting all those multiple people coming into them and telling them they need to come to this appointment, they need to be at that appointment. This is my role, this is why I'm supporting you. All that is done through us. So the family actually only sees our support workers from day one to the end of the clinical support part, which is key because we develop that essential partnership, that essential relationship, with the family that is key to promote service, continuation of services with the family. The second model we provide for the community is the prevention and awareness model. And this is essentially the home visitation model. So when we talk about a modified PCAP model, all we took was the core components of a home visitation model and made it work for a First Nations community. We understand they're going to need one-on-one. We understand it's going to be individualized and specialized for that family. And we understand that we're going to have to be the ones that are going to have to do all the legwork for this family. So what I love about the home visitation model is that it works beautiful within our community because we make those important connections that we need with the family. So the one-on-one is most important with families. And then with an FASD diagnosis, we're able to provide efficient support services. So we actually know what's going on with this family. We know what they need, we know where their struggles are, but at the same time we know what their successes are. And we know our community in general. So if we know this family needs support services from disabilities, we're there making those connections, we're there making those appointments for them and getting them hooked up to those services. If we find that community is just tired, the family's just tired from what they're doing with the child and banging their head on the wall, we're there with them because we're able to provide support services and helping them structure the child's daily living skills. So a lot of the core components from home visitation we use and implement with home visitation with our families. So 80% of the job is home visitation. So we've taken those important core components and implemented them with our case management. So what we've done here with this model is that we've wrapped around the services. So we train our community as well. Education is important with FASD awareness. And we know that it changes continuously. We know there's always new stuff happening out there and new things added that we can support families with. So we educate everyone from Head Start to our college, to our teachers, to family services, to community itself. And the one thing I like to say about our program is that we do surveys within the community. We ask what the community knows, what they need from us, and how we can support them. So we go out and we do surveys at different functions so that we know how to better support the community at large. And these surveys give us beautiful information because then we gear our awareness, prevention, and education around what the community has told us. So we do a lot of health promotion and awareness, and it includes a diagnosis and intervention as well. So we really tried to look at the key components of an FASD model of a clinical services and home visitation and really wrap them around the Siksika community and what is needed at that time for our people. The third model I have here is our traditional care model. Like I had said, we are First Nations, and a simple PCAP model, from my own experience, doesn't work for First Nations community. There's a struggle there because we are First Nations. We don't have that commitment that we'd like to have from families in the way that it flows. So with making it adaptation to the community's needs, we also look at the traditional part of it and that we are First Nations. So we involve our elders, we involve traditional teachings in parenting, we involve traditional teachings in awareness. Elders are key people in our whole programming. Anything from providing presentations to the community to providing home visitational support is what we try to provide for the community. And we know that our culture is what these children grasp. It's what these children love. It calms them. We know that our traditional music calms children down when they're becoming agitated and frustrated. We know that dancing also soothes these children. So we use a lot of our traditional culture in teaching these families how to care for their children, but we also provide elders along that process, so they're getting that traditional support as well. So we include our traditions, our culture, in the whole model throughout it, from day one, from the home visitation to the client case management to the awareness process. So our culture and our pride is most important in providing programming. One thing I'd like to say, sorry, just a moment here. One thing I'd like to say with First Nations is, with the traditional PCAP model, services are wrapped around the target mother, the high-risk mother. With the modified PCAP program, we wrap our services around the child, because with First Nations, our children are the most important person in our community. So wrapping our services around the child has made a huge impact in our program services, and literally has been a success, made our program a success, because our focus has moved from target-centered to high-risk mothers to target-centered children within our community. So essentially, that's how we put these three models to work for the FASD program within the Siksika Nation. I've just kind of created a continuum of care, assessment and diagnosis, which I talked about, the comprehensive multidisciplinary team that comes out to Siksika. Awareness and prevention, which includes community awareness, home visitation within the community, and across the lifespan, so providing supports for adults who are diagnosed or suspected of having FASD. And that's what makes this model so unique for First Nations community, because we have hit all of those three target areas within the FASD programming, and it essentially has made it a success within the community, because we're able to be so innovative in how we provide services to the community. So like I had mentioned earlier, we provide our support right around the child. So when we're doing programming, when we're doing awareness, when we're doing case planning, everything is child-centered. Anything we do, community supports, the work I do advocating for the program, is all based on the child and how to better support that child. Because once we know how to support that child, we're able to provide success for that child. So with the FASD program with Siksika, I had talked about the 3 pillars of support. With FASD, we do assessment and diagnosis right at the center. We provide that service right within the community. Children don't need to get access this support. The assessment and diagnosis, like Suzanne had mentioned earlier, we get a lot of support from Family Services, Siksika Family Services, and the referrals from Siksika Family Services are about 75% of what we get with referrals right now. The remainder 25% comes from the community and the schools. So Siksika Family Services has a huge part in supporting the program and also continuing what we're doing with supports. The second pillar we have is awareness and prevention. So we do a lot of awareness within the community. Like I said, we have the surveys. We do info sessions for the schools. We do info sessions to service providers and the community at large. We always try to be at any event that's going on in the community to provide our awareness to the community on what we're doing, how they can access services, and how we can provide services to them. So there's a lot of presentations done in the schools. There's a lot of presentations to educate the agencies and the teachers at large on how to support children in the school settings, how to support children when providing support to the families. For example, we just finished training the family service workers on strategies, the 8 keys helping children build better successes. So we're always looking at innovative ways to support our community. We also provide supports for the adults within our community. One of the gaps I know that we had, most First Nations have, is that there's really nothing there for when children turn 18 years of age. So most support services are offered within the city, which is a huge barrier, like I had mentioned earlier, because transportation isn't accessible. So having our program out there and provide this lifelong support is key in providing success for these adults. So we provide one-on-one support for the adults in the community, and diagnosis is just as important for adults as well. So with the diagnosis with adults, we have a partnership not a partnership, but we turn to Medellin Clinical Services as well, who are really good in providing the FASD diagnosis for us with our adult clients. So those were the 3 pillars. What makes this program even more unique, and I can't stop bragging about it, is that we've hit the 5 pillars for the child and youth ministry. So yes, we provide prevention. We provide that awareness. We say this is what FASD is. We try to get there in at early ages. So we go in at Head Start and we tell them this is what it looks like. This is how it can be prevented. And we also talk to the teenagers because we know at their age, they're at most high risk. So we're doing a lot of legwork within the community to prevent this, this disability from continuing within our community. So again, early intervention. Intervention and support. So we do a lot of intervention, like I had said earlier, but we provide a lot of support services, not only to our clients, but to the agencies as well within our community, because there's no one else to turn to. There's no one else within the community because of the barriers and the lack of services within our First Nations community, that we're the people that are educating them on what FASD is. We've taken an Aboriginal approach. We've included our culture within programming. We looked at how important elders are in programming. We looked at how important our traditional teachings are with raising our children and having traditional parenting. We've really taken what we are and helped these children identify who they are as First Nations. And we do quality assurance. We're always evaluating our programming and looking at what our best practices and how we can continue doing that. So I mentioned earlier, we've done community surveys. We try to do yearly evaluations on our program, looking at what's working and not working, and how we can provide better services for our community at large. So the first part of our program, the program outline is prevention and awareness. Prevention and awareness within our program is a lot of home visitation. It's a lot of one-on-one. It's a lot of looking at the structure of how we're going to provide that support. For example, with a child that has been diagnosed with FASD and given a 4-digit coding, their specific needs are identified. Their specific challenges are identified, which becomes a huge overload for not only the caregiver, but the school and the family services worker if they're under family services, and the community at large. So what we do as a program is, one example is when we have a child who is diagnosed with a 4-digit code or an FASD diagnosis, we provide support services wrapped around this FASD assessment. So we educate the family on what this is, what it looks like, and how they can support the children. Lots of materials are provided to the family, visual stuff, hands-on stuff, whatever they need. And whatever the assessment has guided them to use, we give that to the family. But another important component of that is also the school setting, because we come from a First Nations community where they have huge classrooms. So you'll have a classroom of 30 students with 1 teacher and 1 TA and 3 children in there who have an FASD diagnosis, among other children who are dealing with their own issues. It's a huge load for the teacher. So what we try to do is we go in and educate the teacher on supporting the individuals in there that have an FASD diagnosis. Because the beauty of a FASD diagnosis, it tells you exactly what's going on with that child, exactly what support they need, exactly how to support them. So we're trying to help the child succeed not only in the home setting, but in the school setting as well, which is a huge part of that child's life. Because 75% of this child's life is in the school, and then the remainder is at home. So they need a lot of structure, which we're aware of. They need a lot of support, and they need that to be a continued continuum of services, basically. So educating the teacher on how to support that child is one key component that we do with the FASD assessment. So that's along with home visitation. So when my mentors go to the home visits with their clients, this is exactly what they're doing. They go there with that assessment, they go there with their case plan, and they sit with that family and they strategize how they're going to support them through this whole process. One key thing they need is we need a lot of supports from agencies within the community. So we need disabilities on board. We need family services to fully understand FASD and the importance of having that family supported from day one. We know these parents need relief. We know that FASD is such a huge load for them. So my job essentially is to make sure that they have these supports and services, to make sure that these parents are supported from day one, and that they're looked after just as much as the child is looked after. So it's a continuation of service. That's what makes this program so important, is because we know the importance of family. We know that it's a backbone of our community. These children are our community. So we know the importance that providing the services includes the whole family itself. We also know that within a First Nations community that family doesn't just mean mom and dad and the child. Family could mean the auntie, family could mean the grandmother, family could mean the first cousin. So when we're providing support to the family at large, it doesn't just come with the nuclear mom, dad, child, and brother outcome. It actually comes with a whole other agenda of people. And we identify that because that's how we are as First Nations people. So when this child is provided support, we include all the members that are involved in that child's life. The assessment and diagnosis part I've talked a lot about. We wouldn't be able to do this work without Renfrew Educational Services and the huge support they've given to our community. They've offered supports in coming directly out to the community and assessing the children at the health center. So when a child is going through a clinic process, the psychologist, the occupational health, and the speech and language come to the center itself, and they do their testing there. So they've actually scheduled their services to come out and test that child so that the child is only brought to the health center where they're comfortable with, where they have familiar faces they know, and they come in and they do their assessment. What happened previously was that these children were asked to go to the city, to Renfrew, to have this assessment process done. But it wasn't a success. Like I said, transportation is a huge barrier. Leaving the reserve for some families and children is traumatic because they're not used to that. Getting there and having to commit to the timelines of an assessment because they're so time sensitive, we set that family up for failure from day one. With having it within the community, we actually set them up for success because, like I said, having a familiar face, knowing your auntie works there, knowing your grandmother's in the nursing part, knowing your uncle's down the hallway with human resources is a huge, huge safety net for these families and these children because they're coming to someplace they know, it's familiar for them. So that's what makes our program such a success because these children come in comfortable. They come in wanting to do the testing, they come in, it's completed and it's done. So having that support and having it within the community is key within First Nations community. Lifelong supports. So when I had talked about with adults with FASD, it's a huge gap for most First Nations communities because we just don't have these resources. We're fortunate in Siksika because we have this service, but we know a lot of First Nations don't have access to supports for adults with FASD. What makes this program a success with the adults within the community is we're First Nations. We know one another. We know our families. So having said that, because we know our families, we know that how to get a hold of this person, how to get a hold of that person. We also know that with an FASD diagnosis, it's not going to be an easy process as a child diagnosis because of the paperwork and the legwork done with that. So having those familiar faces, having those familiar stories, and having people we can turn to helps us with this process as well. The individuals that are involved with the program, the adult individuals, have their own support system within the program itself because they know us, they know each other, so there's a support system that's built within themselves as well. So we do a lot of support services for our clients. We have monthly support group meetings, for example, that look at educating parents and caregivers on basic FASD 101, on basic parenting. We also do interactive children activities. So with our support group session, the whole family is involved. We don't exclude anyone, and we just teach them, we educate them, but we also include the importance of self-care and taking care of themselves and having time to spend with their child as well in a calm environment. So with working with adults and caregivers with FASD, it's a lot of outer brain concepts. So looking at what's outside the box, not looking what's inside the box. Because with First Nations and FASD, we really have to look at what do we have within our community to support these people and being innovative about it because we have a lack of resources, but also looking at, okay, how can we have easy access tools for them as well. Because like that second slide I had showed you, our reserve span is huge and large. So providing the support services is really innovative. We have to be on our feet all the time and thinking about how we can provide support to our community. I want to stress here that I can't stress enough the importance of community partnerships. With the home visitation model, one of the key components is partnerships and networking. So we've taken that important concept of home visitation and applied it with the first FASD program within the community. So my job is to go out to all those services and tell them this is what we do, this is the support we give to community, and this is what FASD is about. How can you as an agency support our clientele, because most of the time we're servicing the same client. So how can we begin networking services so that we're setting this client up for success? And not having that client have multiple people coming in and telling them, this is how I'm going to support you. This is your case plan. And then the next person coming in and telling them the same thing. So we really try to wrap our services around the individual so that we're the key person that they identify with. And it is my job to go out there and access other services and get their buy-in to support our services. So income support, helping them with their AISH papers, helping them with disabilities, helping them access relief care. That's my job, to go out there and create these community partnerships within the community. Another big one is Siksika Justice. So we know a lot of our adults within the community are reoffenders, and we all know that with FASD, it's a huge, huge barrier within a First Nations community accessing support with justice, reoffending, having them in the jail population. So with our program accessing that partnership and having the lawyers understand, having the judges understand the importance of knowing this individual, first of all, is FASD, and knowing that reoffending, yeah, it may be something bad in a condition they broke, but at the same time realizing that it's a disability, it's a barrier for that individual, and giving them a harsh sentence, sending them back to jail maybe the 10th time isn't the answer. So Siksika Justice is one of the agencies within the reserve that we try to provide partnerships with so that we can provide better supports for our adults within our community. A little bit on how our program is doing so far. So we have a 5% in community awareness, and how we know that is we provide community surveys to the community, asking them, what do you know about basic FASD 101? How can we support you? What services would you like to see from us? And we do these probably on every other month basis. And we go out, we're creative and we're innovative. We use that outer box concept. And we go out to community events. Something as simple as having a diabetes walk. We're there and we're providing our surveys and asking community, what do you know about FASD? So we're out there, standing out sometimes at the administration building and just asking random people, what do you know about FASD? Is another way of us getting the surveys completed. Going to the schools, going to the colleges. We go out wherever we can, whenever we can, to get the information from the community. With the program referrals, we're noticing that there's a 1.6% increase in referrals coming into the community because of all our hard work, all the legwork we do, all the awareness we provide within the community, that agencies are becoming aware of us, the community is becoming aware of us, and they're reaching out for that support because we're very supportive and non-judgmental in how we provide support to the community and how we go out there and present ourselves. And what makes it a bonus for us is we're from the community. They know our families. They know us as people. So community referrals have increased for our program since I had started 2010. Our informational sessions with our clients has a retention rate of 28%. We get a huge load of clients that come to our support sessions. And like I said before, it's not just families, they come with their support as well. So we'll have a whole family there, mom, dad, baby, sisters, and grandparents that come to these support sessions because they want to become aware of how to support each other with this child that has been diagnosed. So we always have a huge amount of people attending our support group sessions. Currently, we have 39 children involved in our program, which includes not just children, that includes the family itself, the foster parents, and whoever else is involved in that child's life. And we have 19 adults enrolled in services. So we do have a huge load right now between 3 workers, and we do know that we lack in areas as well. But we are looking at how we can better support our community. And doing what we do and the support that we provide, I think is just a huge success within the community because FASD and the stigma behind it isn't as prominent as it was 10 years ago. So I commend the Siksika community in accepting the FASD program as they have. That's the end of my presentation. I think we'll go into questions.
Yeah, so the first question we have is, you talked about the results of the program. Is FASD declining in the community?
Honestly, because we've just moved away from slowly moving away from the stigma of FASD and the individuals coming into the community, I can't say it's declining right now, but there's a better awareness of what FASD and the prevention of it. With FASD, there's a lot of stigma, yes, but within First Nations community, it's huge. So it becomes a hidden word that no one really wants to talk about. It's taboo. So the declining in the community, I can't say offhand if I'm witnessing that, but what I am witnessing is the awareness part of it. Like I said, we provide awareness to even Head Start children. And we have children come up to us and say, "Teacher, I remember what you told me, and I'm gonna watch my mom so she doesn't drink." So just little stuff like that, I know we're making a big impact within the community. But I'm sorry, I can't say if it's declining right now.
Is there any publicly available research or surveys that shows the results of the program?
No, sorry, do you want to come, Suzanne?
Can you repeat the question, please?
Is there any publicly available research or surveys that show the results of the program?
There's not publicly available research that is available because we are funded through Health Canada and funded through CFAN. The results that we have, the evaluation results that we have are kept within the community. So if you're looking specifically for data or for statistics, that information is not specifically available. But the information that we are sharing with you is available in terms of that. One of the things that I want to say about the previous question is that because we are now tracking the rates of FASD within Siksika, just over the last few years, we are going to see what we would say a rise in, say, the rates of FASD within the community before we see an actual decline. And that's simply because we are collecting those kind of numbers now, and Really what the awareness program is, and the support program and the home visitation program that Vanessa just explained, it really is a relationship and a support program. And so it's going to take a few years for people to become aware of it, to become comfortable with it, to learn what the behaviors are and what they should and what they shouldn't be. So we are going to see a rise in those numbers, and that doesn't necessarily mean that there's a rise within the community necessarily. It's just that we're hearing a lot more about it. And in order to change people's behaviors and to come to a recognition of what FASD actually is, that's going to take a few years. And I would say probably if you ask the question again in another 5 years to another 10 years, then we can give you, we're establishing really a baseline right now, and then we can start to really track those increases and decreases and the overall impact of the program. The number that Vanessa came up with, 1.6% increase right now, is because we've been tracking over the previous 3 years. And so really over the next 5 to 10 years, we really are going to be able to see the true benefit of the FASD program. We know it works because it is culturally based, it's family based, and it's community based. And we know that the follow-up in the home visitation program and wrapping those services around that child is the focus. We've had direction from the elders in building this program. We've had direction from the cultural community, and we've also had the direction from all the experts in the FASD field, including the cross ministry with the 5 pillars that we also follow.
So our next question is, we have a viewer who's in Saskatchewan and is looking to share resources with colleagues. Do you have any particular websites or online resources that you would recommend they check out, specifically for family support workers?
Family support workers within First Nations?
Not sure on that one.
My best advice would probably be to access to home visitation training through, I'm thinking they still offer it under AVNA, which is what we got trained under as home visitors, with resources for, the community or workers. We just did a lot of touch and go. We just looked at what was available, what was online, what CFAN could provide for us. At the time, what CMC was providing for communities. It was a lot of touch and go, and it was a lot of what was given to us from other service providers, and we just took what would work for our community. So we don't really have something specific to resources for agencies. We just looked at what was available for us at that time and what we continue to do right now.
I would have to say that one of the strengths of the FASD program on Siksika is that we took those pillars that were given to us, those guidelines, and we adapted them because we know the community, we know our own community because we work within it. And so the biggest recommendation I would say for First Nations communities in developing their own FASD programs is look at the resources that you have within your own community. Draw on those resources. Don't be afraid to make those partnerships because we know that within our own First Nations communities, we're very frequently challenged with resources. For example, we're currently having challenges in terms of accessing a full-time pediatrician. Dr. DeBanning is since retired, and now we are looking at the different options that we have available to us. We are talking to Renfrew through the different options for a medical diagnostics team, and we're looking at possibly a nurse practitioner that actually comes out to the community as opposed to a pediatrician. So explore all those options within the community. Do an environmental scan of what you actually have within your community. If you don't have those resources within the community, look at the communities around you. If you're part of a tribal council, look at what's available to you through the tribal council, and then what's possibly available to you within the nearest city, the urban environment. One of the challenges that we have is within First Nations communities is very frequently we don't have that infrastructure and those access to services that people have within an urban environment. So we really have to identify where are those resources within the community. So it's okay to take, say, the 5 pillars of the PCAP model or the cross-ministry model and adapt them to your own community. Relationship building, integrating of culture, home visitation. Those are the 3 pillars that we're really drawing on, as well as the MDT, the medical diagnostic teams. Form those partnerships if you need to, and if you can.
So our next question is, are there any specific supports in your program in relation to housing?
It's hard. Housing is aware of our program. Like I said, we do a lot of info sessions within the community, but within a First Nations community, housing is a huge barrier. Probably one of the first, like, I don't know, not pronouncing right, but a huge barrier within the community because there's a lack of housing. So accessing housing for our families is a challenge. Getting them stable housing, I know, is an important core component of the home visitation model, but realistically within the First Nations community, it's a barrier that we face. It's something that we are still trying to work through. It's a challenge. And not only that, we had the flood, which actually put services back with housing. We're like in the back burner along with other key people within the community that need housing because of the flood itself. So there's a lot of huge barriers around housing that we're trying to still figure out with our program.
How does your program deal with referrals, excuse me, that family members are not supportive of?
Within our community, I'd like to say that we actually haven't come across that barrier. The way we approach referrals is, like I said, there's always that key person within the family that has the buy-in to have this individual assessed for an FASD assessment. There's usually a grandmother, there's usually a mother or an uncle that are the ones that reach out to us that actually talk to the parent before we talk to the parent. But they have actually reached out to us first to get educated about what we do and the support we can provide. So when we actually do approach the mother or the foster parent or whoever is caring for that child, we get their buy-in right away because, like I said, within a First Nations community, it's not just mom and dad, it could be grandma, uncle, or aunt. So it's a lot of talking with family members, with support services. Who is their best support and how are we going to get the support from them? We also talk about the importance of the child. So a lot of it is there's a lot of empathy behind it and the understanding that it's a taboo topic.
And I think that's where the and the education that is a large part of the Siksika program is that there is a large emphasis on educating the overall community. And we're not just educating the parents of the who have a child who has FASD. We're educating the community at large. And so we're not targeting just one specific family or one specific group. We're educating the overall community. And because we live in fairly small communities, it's really important to educate that community. And this is where we're saying it's relationship building, it's education and awareness, and it's really letting the community know this is what this is. FASD, we don't talk about FASD. It's on par with, say, suicide. We don't talk about suicide within First Nations communities. We don't talk necessarily about drug addiction. And we don't talk about all those different types of afflictions that are realities within our communities, but we should, because we live with them every single day. And FASD is one of those symptoms of, we could say, intergenerational trauma. And so we're talking about a larger infrastructure that needs to be addressed within the First Nations community. So education, awareness, working with the family, and those relationship buildings, I think in our capacity, in our experience, has really helped in terms of that family being willing to work with an FASD diagnosis and to kind of reduce that stigma overall. So, and I think that's what Vanessa is talking about. We haven't had those large encounters yet in terms of people resisting. But we know that they're out there because that stigma is out there. So it's part of a very large process in terms of awareness and education within the community, and it is going to take time. We've been working with this FASD program since essentially 2006, when we first started up the clinic. So we've been educating and working with the community for a very long time period, and it's still going to take quite a bit of time.
Our next question is, do you partner with medical professionals such as family doctors in Siksika to ensure that they talk about alcohol to women who are either wanting to get pregnant or are pregnant?
Yeah, that's one thing we do with the prevention part is we go in and we educate the nurses and the nursing staff, community health on FASD 101, on strategies to support and safe talk on FASD. So when we have had doctors that have referred mothers to our program, wanting that support from us on FASD. We do a lot of intervention that way as well. So absolutely, talking to the medical field within Siksika, and that's what makes the beauty of the center there, is that the doctors are more open to support services. So having us come in there and talk to the mother is something we'll do as well.
Our next question is, the original PCAP model provides mentoring with pregnant women or new mothers. It sounds like you've expanded this model to children and families, but are pregnant women still accessing your supports?
That's one thing I should have identified from my presentation, but the support services we offer start from the age of 6. So we don't offer support to the mother, the support services to the pregnant mother. We do have a maternal child health program on our reserve who we work closely with. When mothers are referred to our program, we refer them to their program and we work closely with them so that if they need our support services in the future, they're able to access it. So we do a lot. That's part of one of the key partnerships that we do within the community so that these people aren't falling through the gaps. They're still getting support somewhere.
Do you find that teenagers are receptive to the information presented to them?
Actually, that depends. With our presentations, the presenter that presents to them, Michelle, like I said, Michelle Weaselhead, she's very unique in how she provides her presentations to the teenagers. And she's gotten really good response from them, which is actually surprising because teenagers are very hard to provide information to. So within our community, we do probably about 4 times out of the year, we go into the high school and we provide FASD one-on-one. The way she's done it is we don't make it dry. That's one thing I'm going to stress here is with FASD, it can become very dry in how we provide the presentation. And we can't help it because a lot of it is medical stuff. A lot of it is what it does to the brain, what it does to the baby. And with teenagers, what we've done is we've been innovative. We actually created our own FASD Jeopardy, which talks about FASD, but at the same time it gets the kids buy-in because they're learning something and it's something fun to them. So when I talk about thinking outside the box, that was us thinking outside the box with teenagers.
How many clinics do you host per year and how many people does that involve?
It depends with Renfrew Educational Services and their timelines and our timelines. It varies from about 3 to 5 clinics per year, and we have about 3 children per clinic. So we can have about 9 to 15 children a year, depending on how many how many clinics we can have with our services and Renfrew.
One thing that, just to add, is that when we first started the clinic in 2010 again, with Dr. Debanning, the focus was on the diagnostics for the children. And so we had 5 clinics. Renfrew was able to provide us with 2 traveling clinics, and then the rest we had to pay for. And so we had 15 children, 5 clinics. And now that we've reevaluated and readapted the Siksika program, there's a real emphasis on follow-up and home visitation now and the relationship building. So we've shifted our focus to the family and towards that child. And so now we are diagnosing 9 children per year. Simply because we want to ensure that the individuals that we are currently working with get those full follow-up services and those supports that we can provide to them. So we know that we have a very large population on Siksika, and year by year, as we work with the program, our focus is probably going to be on in between 9 to 12 individuals with a full spectrum of really good supports and follow-ups.
And one last question. Do you offer transition programs for young adults 18 to 25 affected by FASD for transition to adulthood?
That's something actually we're starting this year. So it's a partnership with Family Services within the nation and helping those children to exactly that, transitioning them from being teenagers, youth, to adulthood. So we don't really have a specific program for them. What we're doing is we're doing the home visitation model with them and helping them access services that will set them up for lifelong successes. So looking at how we can support them to become responsible, having them have structured environments, looking at optional housing issues, just providing them the best support, living supports that we can, because a lot of them do fall through the gaps so that they're not becoming homeless, they're not on the streets, so that we know how we can support them. And it's a partnership that's between us and Family Services and working with them closely and identifying how that's going to look. So it's actually something we're doing this year.
Yeah. And that's what the overall mandate of community wellness is within the larger Siksika Health Services, is to provide those supports for through the lifespan, from the time that a person is very young to the time that they're elders. And so that's what that we are looking at is those transitions, and not just FASD, but in all the different programs that we have. But of course, we have to look at the funding, and we have to look at the infrastructure that we have within the community. So we are looking at that. Mm-hmm.
Thank you so much.
You're welcome.
I'm just going to slide in front of you here. Thanks again to our presenters, Vanessa and Suzanne, for taking the time to present on the Siksika Health Services FASD program. Please stay tuned for information on next month's FASD webcasts. To get updates and registration information about each of the sessions, please email us at fasd@gov.ab.ca and ask to be added to our mailing list. You can also find past and future webcasts at fasd.alberta.ca or sign up at hslearningservices.ca. Today's webcast was recorded and the video will be posted online, along with videos from previous webcasts. The link will be sent to all registrants in the near future. We encourage you to share this video with anyone you think might be interested. And if you have feedback about today's webcast, please email us at fasd@gov.ab.ca and let us know. You will be receiving a feedback email from us. Please take the time to let us know what you thought of today's webcasts. We'd love to hear your ideas. Have a wonderful afternoon, and we hope to see you at our next webcast.